Thank you so much. Assalamu alaikum, everyone. And thank you, organizers, for this opportunity. And actually, it is a privilege to be here. Myositis is my topic of interest, and myositis is a rare disease as compared to the other diseases discussed earlier today. But still, it is interesting and fascinating and challenging at the same time. So, okay. So this topic is also quite relevant because every patient, every other patient is entering the rheumatologist clinic with a report of antibody. So there is a story behind each antibody result. And this story defines the diagnosis, stratify the risk, and help to guide the treatment. So today we will discuss how this story, how the myositis-specific antibodies bring this story to the bedside. So this is my institute. It is my parent institute, and I think it is the parent institute of many of the rheumatologists, leading rheumatologists who are sitting here. And I'm thankful to my mentors, Professor Abid Faruqi and Professor Wajahat, for mentoring us. Thank you, sir. So I will start with a warm-up case. This is case of a 52 years old female, and she has presented with proximal muscle weakness. Her muscle enzymes are raised, and she has mild ILD. So the question arises that whether this patient has inflammatory myositis. Does she need extensive workup for malignancy? Will she develop rapidly progressive interstitial lung disease? And is rituximab indicated for this patient? So now one antibody can answer many of these things. Now I'll lead you through the discovery of myositis-specific antibodies. It dates back to 1976, where first antibody, anti-MI2 antibody was discovered, and it was followed by discovery of anti-SRP, anti-Jo1 antibodies, and then other anti-synthetase antibodies. Now recently, two more antibodies, anti-LY and anti-VRS, have been added to this group of anti-synthetase antibodies. Two other antibodies, CCAR1 and SP4, they define cancer risk or stratify cancer risk in patients with anti-TIF1 gamma antibody positive myositis. So these are the 10 different anti-synthetase antibodies, and out of which anti-Jo1 antibody is the most common, followed by PL7 and PL12. And the two new included in this armament, in this group, is anti-LY and anti-VRS. So now coming to the different phenotypes of the inflammatory myositis. And these phenotypes are not only the clinical phenotypes, these are clinico-serological phenotypes, where the clinical phenotypes is supported by the serology. So the advent of myositis-specific antibodies have facilitated the recognition of multiple homogeneous groups within the inflammatory myositis. And true polymyositis is much less common as compared to it was thought before. And those patients who were diagnosed to have polymyositis according to the Bohan and Peter criteria, they later on ended up with an alternative diagnosis like antisynthetase syndrome, immune-mediated necrotizing myopathy, overlap myositis, inclusion body myositis. And so this clinico-serological diagnosis have led to the diagnosis of polymyositis. Rather, it is now rudimentary. So these are the different clinico-serological subtypes of dermatomyositis. The typical dermatomyositis involving cutaneous and muscular manifestation is seen with anti-SAE positive, anti-MI2 positive, and anti-NXP2 positive. So out of these, NXP2 antibody is associated with calcinosis in children, and it is associated with higher risk of malignancy in adults. Anti-MDA5 antibody, it has some specific characteristics, like it is associated with rapidly progressive ILD, pneumomediastinum, inverse Gottron, and cutaneous ulcers. And it is also important and different from other entities because it is associated with clinically amyopathic or hypomyopathic myositis. Now coming to the anti-TIF1 antibodies. As already discussed, CCAR antibodies define whether the patient with anti-TIF antibody will develop CA or not. So if the patient has anti-CCAR antibody positive, they're less likely to develop carcinoma as compared to those who have negative anti-CCAR antibodies. Anti-synthetase antibodies can be divided into anti-Jovan and non-Jovan antibodies. And Jovan antibody positive have got interstitial lung disease, and in addition to the musculoskeletal other systemic manifestations. And non-Jovan, in which anti-PL7 and anti-PL12 are more common as compared to other, and they are associated with severe lung disease and progressive lung disease even in the absence of muscular symptoms. Necrotizing, immune-mediated necrotizing myopathies. These myopathies can have anti-SRP positive. They can have anti-HMG coreductase antibody positive, and at the same time, they can be seronegative. So now coming to the myositis-associated antibodies. What are myositis-associated antibodies? These are antibodies, they are not specific for myositis, but they are associated with other connective tissue disorders. And these antibodies include anti-Rho52, anti-KU, anti-PMSCL, anti-U1RNP. And these are associated with higher prevalence of lung disease. These myositis-specific antibodies can be present in combination with myositis-specific antibodies. They can be present in combination. And when these are present in combination, there is high risk of interstitial lung disease, and it needs closer monitoring and aggressive treatment. Now coming to a scenario. This is a 27-year-old male who has progressive muscular weakness for last 6 years. There is no history related to connective tissue disorder, no cutaneous, and no lung manifestations. There is no history of statin or steroid use, and there is no significant family history of any muscular disease. His muscle enzymes are raised. EMG show features of myopathy. ANA and ENA are negative, but his anti-MI2 antibody comes out to be positive. His MRI of thigh was done, which showed myofiber necrosis, and in addition to that, there was extensive fatty infiltration and a few patches of inflammation. He was given a trial of steroid, which showed improvement of muscle enzyme, but there was no improvement in power. Rather, there was a worsening of power. So I would like to have your opinion. Will you restart steroid? Will you immunosuppress him? So in the coming slides, we will see the answer of these questions. Although MSAs, they have high specificity, they have low sensitivity, but their specificity is quite high. But interpretation requires clinical, have certain limitations, and there are laboratory limitations in interpretation of these antibodies. So just an isolated positive antibody does not confirm the diagnosis of inflammatory myopathy. Diagnosis requires clinical phenotype, and in addition to that, supportive investigations. So there are many limitations of the laboratory interpretation while interpreting the patient's result and clinical phenotypes. These include false negatives test. There are discordant results between the line immunoblot and immunoprecipitation test. There are multiple false positive tests, which are clinically insignificant. So what is the reason of these? Either there is different commercial assay with different sensitivity, or lack of international standardization. So these are the two assays which are available for the detection of myositis-specific antibodies. These include line blot assay and immunoprecipitation assay. The line blot assay is cheap and it is commercially available everywhere. So this is cheap, but it has limitations. What limitations? It has multiple false positive tests, including 12 to 13% chances of false positive test. In addition to that, it does not identify these stiff-1 antibodies and anti-synthetase antibodies reliably. The other test is immunoprecipitation, that is accurate test, but its limitations are that it has limited availability and it is very expensive, and only few centers offer this assay. It does not reliably detect these antibodies, Rho52, HMG co-reductase inhibitor, and anti-C1 2. So this is the line blot assay, which is commercially available everywhere. It is a strip which includes the following. These are the MSAs which are detected on this strips, but it has limitations as already mentioned. So interpretation requires clinical context because there are false positive. In addition to that, there are various reasons for a false negative test. So it should be interpreted in the clinical context. So do not overcall the disease when there is single antibody positive and there are no symptoms. And do not undercall the disease when there are symptoms but antibody results are negative. Another question, and other important question, do we need to repeat the test? So it is rarely helpful until the patient has changed the phenotype or you order it from a specialized center or there is some doubt on the original test. So now coming to the case of that young boy, this is the genetics study of that young boy. Sir Javed is sitting over here. And the primary finding of this genetic test was that there was no variant identified which was pathogenic or likely pathogenic in the primary findings. But in the secondary finding, there was a variant of uncertain significance associated with some recessive dystrophies. But that finding of that variant of uncertain significant, what is it? What is the variant of uncertain significant? It is a genetic change for which there is currently insufficient evidence to determine whether this is causing the disease or it is benign. So this result should be interpreted in addition to the clinical context and other investigations. Now, coming to the my original topic, that is biomarkers to bedside. So now the precision medicine has changed the way we treat inflammatory myopathies. And now we'll see how these MSAs help us to turn the laboratory test into bedside decision. We come to the case, that is a 45-year-old male. He has presented with 2 months history of muscle weakness. He has mild dysphagia and shortness of breath. There is no extramuscular symptom. And this patient has proximal myopathy in the form of neck flexors 3/5, shoulder abductors and hip flexors are 2/5. Rest of the examination was normal. His muscle enzymes are sky high. MRI thigh shows diffuse symmetrical muscle edema. EMG shows irritable myopathy, and anti-SRP antibody is strongly positive. And this is the biopsy, which shows that there are atrophic muscle fibers, scanty inflammatory infiltrate. So coming, as we know that SRP antibodies are positive. So which other test, what is the risk associated with anti-SRP antibodies? Cardiac. Yes, cardiac. So these patients warrant cardiac evaluation in the form of ECG and TROPS, and in addition to that, pro-BNP, echocardiography, and in under ideal condition, cardiac MRI. But because of the limited availability, this is difficult. So how SRP antibody positivity changes the management? This antibody is associated with severe necrotizing myopathy, so it warrants early aggressive immunosuppression, very high CPKs. So muscular monitoring of the muscle disease should be done. Dysphagia warrants swallow assessment and nutritional support. Myocardial or cardiac involvement warrants cardiac evaluation. These patients have poor response to steroids, so early combination therapy should be given, and they have frequent relapses, so these patients should be monitored regularly. So according to the NMAC classification, this NMAC guidelines, this patient is have organ involvement in the form of the cardiac involvement. So this patient should be treated aggressively with IV steroid followed by oral steroids, and then either rituximab or plus methotrexate in addition to methotrexate. So if the patient does not respond to this treatment, it should be rapidly escalated to IVIGs. And these patients should be maintained on this treatment for 2 years because it has high relapse rate. So the management includes, in addition to the musculoskeletal symptoms, cardiac management in liaison with cardiologist and guideline-directed heart failure treatment. So these patients should be monitored for both muscle disease and cardiac disease. So this was all about the SRP antibody. Now coming to another scenario. This is a 52-year-old female. She presented with dyspnea, progressive dyspnea, which is for 3 months, dry cough, fatigue, and inflammatory arthritis. Examination shows that she has low oxygen saturation, there are bibasal crepitations, and there is no objective muscle weakness. Pulmonary function shows restrictive lung disease. Her ANA is positive, but anti-dsDNA, ENA, RA factor, anti-CCP, they're all negative. And her anti-PL12 antibody comes out to be positive. This is the HRCT of this patient. It shows bilateral GGOs, traction bronchiectasis, and overlap with organizing pneumonia. So what does this PL12 positivity imply? What are the implications of patient with positive anti-PL12 antibody? These patients have severe ILD, and ILD may precede myositis, or there may be no muscular features at all. So they have progressive fibrosis. It needs monitoring with HRCT and pulmonary function test, and it has high mortality. So multidisciplinary approach should be adopted for the management. So the treatment for this patient should include IV methylprednisolone, mycophenolate mofetil, and tacrolimus, in addition to the pulmonary rehabilitation. And multidisciplinary care should be given to such patient. And these patients should be monitored for pulmonary disease and for muscle disease both. So this was all about the PL12 antibody positive myositis. Now this is my last scenario. This is a 55-year-old female who presented with rash, muscular weakness, and mild cough. Her examination shows that she had power of 1/5 proximally and occasional crepitations in the bilateral lung fields. Rest of the examination was, except these skin findings, which include V sign and Scholl sign. So the baseline investigations were normal and her muscle enzyme were raised. NCS EMG shows irritable myopathy, and anti-MI2 antibodies were positive in this patient. Muscle biopsy was consistent with dermatomyositis, and there were patchy GGOs in HRCT. So let's see what IMEX guidelines say about this. Because this patient have high risk for malignancy, as she is more than 40 years of age, she has dermatomyositis, so she should go under the extensive malignancy screen. So malignancy screen should be done initially at the baseline and then repeated yearly after for 3 years. Her tumor markers were done and her imaging was also done, and it came out to be negative. So a good news for the patient is that she is anti-MI2 positive, which has a good response to treatment, and she can be given only just the standard treatment for mid-dermatomyositis and monitor for the lung disease and muscle disease. So I, as already told, that this patient had classic dermatomyositis rash. They have good response to treatment with steroids. They have lower risk for the progression of ILD, lower malignancy risk as compared to TIF1 gamma and NXP2, and they have favorable long-term prognosis. So whenever you come across an antibody, define the phenotype, anticipate the key risk factors, order targeted investigations, and then give personalized treatment. So MDA5 antibody, which is associated with rapidly progressive ILD, and these patients should be monitored for the lung disease, and early aggressive combination immunosuppressive therapy should be given to these patients. TIF1 gamma, as most of you know, that it is associated with high risk of malignancy, so enhanced and basic panel for malignancy screening and monitoring for the next 3 years should be done. NXP2 antibody is also associated with calcinosis in children and increased risk of malignancy in adults, so they should be screened for malignancy. Jo1 antibodies is associated with antisynthetase syndrome. HMG co-reductase antibody, it is associated with more pronounced muscular weakness. So extensive investigation should be done to treat and monitor these muscular disease. And these patients may need IV immunoglobulins if the disease is not responding. Overlap myositis, when it overlaps with other connective tissue disorders, it should be the primary connective tissue disorder should be treated in addition to the myositis. These are few current and emerging therapeutic modalities in patients with myositis according to their clinico-pathological phenotype. What are the future directions in personalized medicines? These include multiple endotypes, multiomics, AI prediction models, interferon signatures, and biomarkers in addition to the and beyond antibodies. So these are my key messages. That order the antibodies when there is reasonable clinical suspicion. For interpretation, clinical context remains essential. MSAs, they define the modern classification of myositis. So they predict organ involvement, prognosis, guide malignancy screen and treatment, and let the clinical judgment guide the management, not only just the antibody. Thank you so much. Thank you.